you've been having some issues for quite a while. There's a few things that we're kind of going to be looking at and that we'll be talking about. Essentially, when we kind of go over the knee, the first thing I test for is the ligaments, the ACL, the PCL. Those are the deeper ligaments, deep within here, right? ACL, and then behind it is the PCL. So let's just get rid of this guy for a second. They kind of cross like this. I test all the ligaments for what I call integrity or stability to make sure they're not torn or ripped. So in your case, we are good. I'm just going to show you on this side just to make it easy. All of your ligaments on every single side are fine. The MCL was fine, the LCL, the PCL, and the ACL, they were all fine. When we kind of take the knee apart a little bit and we look down on it, we have the medial meniscus and the lateral meniscus. Here's the lateral, here's the medial. The medial tends to put 80 to 85% of our weight on. It tends to be a little bit bigger, a little thicker, and we tend to wear it out a little bit faster. So what we try to notice in people is that poor biomechanics or improper mechanics can wear a joint down faster. Think about a door hinge, right? If a door hinge is too tightly screwed or not tight enough, it can start wearing out other parts of either the door hinge, or it could drag on the floor and wear out the rug, so to speak. That's kind of like what we're trying to look at. I tested you for the MCL, and by the way, the MCL, this is just I guess you can say a picture. So the MCL actually has like fascial attachments inside there. So it actually attaches to the actual meniscus itself. It's not just like, oh, here's a piece of paper, it just goes straight down. It literally kind of embeds itself with the fibers and becomes one congruent structure. I tested this to see if it was unstable. It was not. It did cause a little irritation, I think, depending on the positioning of the knee for you. I think your knee is very temperamental. Correct me if I'm wrong. Because certain times I did it and you're like, no problem. And then I did it again and you're like, I didn't like that. And I did it again. You're like, yeah, that didn't feel good. What has been very, very consistent on you was knee flexion with some pain. I even tested it in a locked out position and a not locked out position. It seems like when it was not locked out, meaning in knee flexion, it had more pain every time on everything we did. So really, when somebody says a degenerative knee meniscus, it means that the bones are essentially coming closer together and they're rubbing it a little bit too much in there. And you're putting a little bit too much vertical force through that meniscus, and it's causing some compression. I had you do that standing test on one leg that applies your entire load of your entire weight onto one knee, and then when I have you lean into one side or to the other side, we're really trying to corkscrew, one way down to this side, or corkscrew our way down to one side to see which one would cause more issues. Every single time it was over there. So, one of the other things that I have noticed, that you had some weakness on the hamstring a little bit associated with pain. Now, this is super, super common, and I think this is very underlooked. Now, we have the hamstring group back here on the lateral side, but we also have the hamstring group on the medial side. Now, on the medial side, or the inside here, we do have these weak hamstring muscles. Now, most people, if you talk to the average anatomist or physiologist, they'll say that most of the hamstring contraction occurs from the biceps femoris here, and that's true. Okay. The long head and the short head. It does do most of the contraction. But you have to remember that this still does play a role of balancing the knee. So if we contract, let's just say, your arm on just this side, it's going to pull you up into this side. So yes, it may do 90% of the flexion, but there's a 20% of it or 10% of it that will pull it back this direction a little bit, and that's these ones. They also have attachments on the inside of that knee where I first went, and I was like, hey, is that tender? I think these things are working a little bit harder in order to create that stability. And these muscles on the inside of the thigh do attach and cross down to the knee. Obviously, it's that one, but down crossing the knee, and they create some stability. So if you can get some of those hamstrings to support the knee on the inside, I think you'll end up finding some good value in that as well, because it's really about the hamstring that really helps stabilize the knee on the sides. So that's that. I did also test a lot of the patella. You did have a good amount of patellar grinding, so it's not a lot, but it's enough where if we kind of like rotate this person in this direction, we see the side of that. So what we're seeing is that we're seeing a floating bone right there, and then we have the top of that femur, and then there should be some cartilage on this side, there should be some cartilage on that side, and when the cartilage is kind of disappear, they create more of a grinding mechanism. I think that's what's happening a little bit. So you're getting the early phases of degenerative changes. That's okay. I think this is not a severe case, believe it or not. I think the hardest part is kind of saying with a person who is managing hypothyroidism and all these other issues, you might end up finding that it just may be harder to take the pressure and the weight off of it. That's okay. We can figure out some other answers. But if we restore some of your mechanics, I think you're going to end up finding that you'll feel more comfortable more often. I think that, when it came to your hip issue, you did have good strength all the way around from most of the hamstrings. You had good hip strength on the side here, on there. You did have good knee flexion strength. You even had good adductor strength. So it just seemed like every time we got to this lockout position around 90, 95 degrees, it really started to get a little bit more like you could feel the joint was like, hey, I don't want to do that. That's why I asked you earlier. I said, does it lock? If it doesn't, that's a good thing. I don't want it to lock. You don't want it to lock either.
No.
If it locks, it does become pretty painful. You will know, and that's a good indication. Not entirely. It's not a hard yes or no. It's a good indication you may need surgery.
Okay.
I don't think you're there yet. If you need to ward this off for a few years, I still think that's very capable.
Mm-hmm.
I really do. Even if you ward it off for 2 more years, I think it might be very doable.
Okay.
That's my opinion. I know that's like not your timeline, but
Hey.
but I just want to give you that
Yeah.
heads up. What was I saying? I did test a lot of your hip. Your hip is super high elevated. I don't think there's a lot of tenderness, but I do think the lateral side of the hip is just working a lot more than it needs to help bring you through that zone.
Mm-hmm.
That circumduction zone is what we call it, like this. You're doing like this. And I think because you can't do the full knee flexion, you said it actually properly, you're not heel striking right because that puts a lot of pressure on the knee, on the meniscus. And then as a result, you don't have that full bend and the weight transfer. So what you do to help avoid that weight transfer is this.
Yeah.
So if you ask me personally, did this come from somewhere else? I don't think it did. I think you're learning to compensate from the knee. I think the knee is actual knee issue. Some people actually think they have a knee issue. They have a hip issue that's causing knee pain. I have no problem treating symptoms as long as we're getting towards the actual problem. But if we are treating just the symptoms, it's only good for symptom relief.
Yeah.
So I think you actually have a knee issue. I think we can work the whole femur. We also, I did forget to mention, I do think your reduced range is a little bit on the internal rotation of that knee. That's why I had you kind of doing this, and I was flicking your knee. I was like, I think you could use a little bit of internal rotation. That'll help this type of movement. So it'll help take pressure off of that. So a little bit to work with.
What's your timeline?
Good question. I wish I had one. No, seriously.
No. I always ask, and I know most doctors is like, no, it really just case by case basis.
It is, but I always like to say, give it a few weeks, see how you're responding to care, and if you're not getting better, we refer you out. If you feel like it's getting better and it's getting stronger, then great. If it's not getting better, if it's not getting stronger, then we kind of have to talk. Do we have to do more? Do we have to do less? Do we have to send you out and then wait a couple weeks? Or do I just have to say, hey, I think we need to switch up exercises. Do I need to send you to another provider? Because I'm pretty blatant and transparent about that. You don't have time to waste. I don't either.
Thank you.
So, because I really believe that if you just